Welcome to our webinar series for professionals.
Hi, all wonderful people out there. Welcome to this next webinar that we have, which is on continual education. So not on a lab test, not on a supplement, but on your continual education within your field. And today is actually mainly focusing on targeted education on functional medicine, because Nordic and DNA Life has actually for a long time been partnering and sponsoring the education from the Institute for Functional Medicine. I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, a group of companies that's dedicated to change healthcare through functional medicine and personalized medicine. Remember that any tests and supplements that may be touched here, or if you have questions in the question chat, you can purchase them in your VMS account, of course. Next webinar we have is on the 6th of July. It's again with Julia Malkowski, where she will discuss the gut microbiome in relation to different chronic diseases, both obesity, diabetes, cancer, Alzheimer's, and depression. So I'm looking forward to that. The star of today's show is Mike Ash, and he's I might offend you a little bit here, Mike, but I'm trying anyway, and I hope it's not too hard on you. But he's a very young looking old rat in the field of functional medicine. He's done lots of research and education. And for those of you who doesn't know Mike, he's highly educated. He's a highly talented educator. He's educated as both an osteopath, nutritionist, and naturopath. He's the managing director of Nutrilink, which is a supplement company that's supplying VMS with professional supplements, so you can find them in our portal. He's also the editor of Clinical Education website, and he is a rock star within functional medicine education, so you're in for a treat. And actually, I remember that we were in Johannesburg, and you had been on the stage educating in something gut integrity, autoimmunity, and what have you, and you were busy, you had to leave, and there was just like loads of people running after you because they all wanted your autograph or something fun. So he is a rock star. Anyway, Mike, I will pass on the stage to you so you can share the slides and write questions in the chat if you have questions. And remember, we are recording, so the recording will be shared as soon as we can with a mail next week. Mike, over to you.
I'm just going to share the screen, if that's okay. Let's get that underway. And welcome, everybody. And Anne-Catherine, thank you very much for that very generous introduction. I think they're probably chasing me out of the building rather than chasing after me. But anyway, today was really an opportunity to tease out, for those of you who perhaps yet to undertake any specific training in functional medicine, or for those that have already started but are perhaps wondering whether to continue with that process with the Institute for Functional Medicine. As Anne-Catherine has already indicated, she and Chris have long been supporters of functional medicine, and I've been involved with the Institute for Functional Medicine for just under 30 years. So I was one of the only 2 UK participants in the very early training program of functional medicine some 27 odd years ago. And subsequently, I've become 2 things. One, I've become an educator for them. So I do presentations and do educational programs for them. But I also started bringing the Institute for Functional Medicine's training to the UK. And then we extended that to include the EU and the EMEA as well, and also South Africa. So Clinical Education is a not-for-profit organization, which was set up specifically to provide access to not just functional medicine training, but also lifestyle medicine training. So in addition to using what we're going to be discussing in a few minutes, the resources supplied by the Institute for Functional Medicine, we've also developed in the UK the only Royal College of GP approved lifestyle educational program for GPs. And we use that to help many of the frontline primary care physicians understand that a route to health that doesn't involve their more traditional opportunities of pharmaceutical or pharmaceutical stroke surgical interventions can be progressed without using the rather more orthodox approach, but using safe, easy to apply lifestyle approaches can move people to a position of improved health. And then from there, as they get more and more interested in that program, we pull them into the functional medicine education programs we offer in the UK. And just as an example, when we first started doing what's called applied or AFMCP, applying functional medicine clinical practice training, we had about 10% of the attendees were medical doctors. And the last time we ran it in the UK, we had almost 50%. And what's happened is that there's been an increased understanding, mostly around the fact that there's far more literature, either in books, articles, TV, radio, etc., in which the term functional medicine is used. So I only have a very few slides, so don't think there's going to be an exciting run of lots of slides here, but much of this is really based around a sort of conversation, and these are the key points that I'm going to cover off, and then obviously if you have some questions, then please fire away. So the first question that we always get asked really is, what is functional medicine? I mean, how do we describe this in a way that makes sense to people who have no medical training, as well as those who have different types of training? And functional medicine really is an approach that allows you to hear somebody's symptoms and complaints through a mixture of different expert understandings. And it operates by collating information through a web of ideas around 7 principal inputs. And depending on where your primary expertise lies, the tendency in clinical practice is always to emphasize that utilization or that skill set first. And what the functional medicine training is really focusing on is trying to expand your range of interventions, whilst also creating a common language that would mean that anybody else that's been through functional medicine training, who you may choose to use as a supporting colleague, would quickly understand the dynamic that you're trying to communicate to them. But also it permits exchanges of information between those people who have no understanding of functional medicine, but perhaps have an expertise in one of the quadrants that you're looking to get some support in. But also it's there to try and make sure that you as a care provider are not too stuck on only one style of intervention. So as Anne-Catherine pointed out, I've taken a number of different qualifications over the years. And to me, functional medicine provided a platform through which it was easy to apply multiple different disciplines. And the educational program that the Institute of Functional Medicine have put together and continue to evolve is delivered in a series of different stages. And the first is this applying functional medicine in clinical practice, which in the UK this year, we're running this as part online and then 2 days in person. Circumstantially, we used to run these events always as a 5-day in-person event, which were terrifically popular. But because of the changes to education forced on us all by the restriction on gatherings during the COVID period, we shifted to using only an online version. But we always felt that the problem with online education alone is that it's not very easy to develop those meaningful relationships that occur from shared educational experiences. And so we've been very keen to press the Institute that we can go back to, at least in part, an in-person educational program. And they're also looking to see whether the strategy that we have, where we mix both online and in-person, would be something that would suit them for their other educational events which take place in North America. So functional medicine is essentially an educational program that's very detailed, evidence-based. In the States, you can apply for continuing medical education credits, and in the UK, we have various CPDs, and we normally try and organize CPD accreditation wherever we can in different countries. And it provides you some evidence then that you've undertaken different levels. Beyond AFMCP, there are 6 advanced practice modules, which take place over 2.5 days, at the end of which, or at any point during which, you may take the exam to become a certified functional medicine practitioner. And the exam is very comprehensive. It takes a lot of preparation. And at the end of that, you enter a relatively small but growing cohort of people who've undertaken that program. So there's well over 1,000 practitioners that have done that now, and between 200 and 300 a year complete that program. It takes about 2 years just because of the time periods between the different advanced practice modules. So what differentiates this type of training? Well, of course, a lot of the training includes things that will be familiar to you depending on your primary disciplines. What really differentiates it is the intensity of mechanism understanding. If you enjoy the process of working backwards through a set of symptoms to understand the mechanisms that are generating those symptoms, or at least a range of mechanisms, IFM have always been very good at helping you work back towards what they refer to as the root cause. But in simple language, this is rather than being symptomatic, and everybody on this call, I'm sure, is very familiar with the idea that we're not symptomatic interventionists. We're always looking for causal interventional strategies. Functional medicine does a very good job of exploring this at a high technical level. And they do this by bringing in experts from each of these different disciplines that then utilize contemporaneous human studies where possible, or preclinical or animal studies if they're early stage. Having done this now for nearly 30 years with the Institute, what I've been able to see is that it began very much as an experiential process. So experienced practitioners were invited to communicate about their successes utilizing different strategies, and the level of intensity around the quality of education differed quite a bit between the capabilities of the presenters. What's happened over the last few years particularly has been a much higher level of consistency in terms of the quality of the material, the rate at which it is updated. So that you see a presentation take place this year, by the time you come to see it again the following year, there will be some significant advances within the information that's contained. It's a rolling process of delivering up-to-date quality education. There's often a question, and well, don't I already know much of that? Well, of course, we'd hope that you would. The purpose of attracting people to join with the Institute of Functional Medicine is not to dilute the information and the skill set you already have. It's the opposite. It's to add to them, and often to tease out from within that more familiar realm of clinical care some additional skill sets, some additional ideas as to how to utilize that information in a collective approach. And you'll see in a moment when I come through to a slide. In fact, I'll just jump through to one of those slides now. This might be difficult for you to see on your screen, but the visual presentation here is that we have a group of organ systems providing a diagnostic tree structure at the top, which in this case is gastroenterology, endocrinology, cardiology, pulmonary, urology, hepatology, immunology, etc., which comprise the signs and symptoms that people present with. And then underneath that is the fundamental organizing systems and core clinical imbalances that the functional medicine training looks for you to target. Below that are the antecedents, triggers, and mediators. These are what events have either triggered them, amplified them, or have contributed to their causal creation. And then below there, we have a mixture of genetic predisposition, which of course Anne-Catherine has spent many years providing education around that area. And then we have the mental, spiritual, and emotional influences. And below that are various lifestyle interventions that you may wish to explore. If I just jump ahead one, and then I'll come back, is that tree is translated into a chart during the educational process, which we call the matrix. And essentially, this is the area in which you transfer information that you've gathered from the individual that you're looking to help, and you place this into a series of headings. It's quite a small chart sometimes when you're dealing with very complex cases, but it provides you a structure. And the idea is from that structure, you're able to communicate a story back to the person that you're helping and can demonstrate to them how you're combining things like defense and repair or assimilation, structural integrity, and communication around their mental health or their emotional health. And then at the bottom, you have various lifestyle factors that you put in there that you can mediate or change. So I'll come back to that again a bit later on, as it can be a little bit confusing as to see where that fits in. But essentially, this comes to you through a series of stage programs. So the levels of training that are available are baseline, which is the Applying Functional Medicine in Clinical Practice 5-day introduction, which is largely focused on how you collect information, how you translate that into a strategy, and then exploring each of those nodes to demonstrate what type of clinical care could be used. A lot of this is based around nutrition. So if you have a background in nutritional training, it can seem familiar. For many of our physicians that join, who, as you will all know, receive very little education in nutrition during their medical training, it can seem terrifically overwhelming. And what we found over the years is that when people get together in the same room, we encourage our practitioners that have a better or a very complete understanding of nutrition to share geographically in terms of the tables that they're allocated with the medical professionals, who often feel very uncertain and insecure about the level of information that's been taught to them and how they would apply that in practice. And over the years, we've witnessed many successful and fruitful relationships where we have perhaps a nutritional therapist that's become a co-partner with a medical doctor who have a common language that they can share between themselves, and then they divide responsibilities over some of the key decision making. And so most of the GPs that we encourage and support through their transition from the National Health Service to private care are often looking for and hope to team up with one or two nutritional practitioners or nutrition orientated practitioners to provide support in that particular area. So the training is, I'll show you at the end, we have a program that's about to start in the UK. So if anybody was looking to, at the end of all this, to start, it's possible to join. We do quite a significant discount over the cost of doing this training in North America. So there's a $780 discount if you were to do the training under the UK and EU outreach program for clinical education. And the training is available at all times online. It's not necessary to appear in person, but we encourage people to undertake training that does. The training is there to facilitate your own timeline. It's not tied to a very tight process. Some people take 4 or 5 years to go through the different advanced practice modules. Others get highly motivated and fly to the States to try and cram them in where they can, and perhaps manage to do it in 18 months. But our experience of this is that each person finds the pace that suits them. Everybody has a life that they have to manage. There are all sorts of different responsibilities, and these are rolling educational programs. So if you miss one of the advanced practice modules, there'll be another one within 12 months after that. In the States, this educational program is validated by American medical institutions. And in the UK, we have CPD approval. And for Royal College of GP attendees, they're able to apply the hours that they spend undertaking these programs and self-certify for those hours. We also have some additional external validation for the other course I mentioned to you, which is the, if you like, the teaser course that we do, which is prescribing lifestyle medicine. So we try very hard to make sure that the quality of the content of the course is going to improve the individual's capability of delivering care, and also that it satisfies whichever educational group we're seeking postgraduate support credits for. You can apply this in clinical care at different levels, and it's very tempting when you first start with this program to rush at an individual, and you're burdened to a large extent with a massive amount of information which you wish to apply and overlay. And it can be a bit overwhelming for both the practitioner and the patient. So the time you've allocated to spend with that person can quickly run away from you. All the information you can provide can be so overwhelming that the poor person who didn't feel very well when they came in now feels thoroughly confused. And so applying this in clinical care comes a large part from understanding the capabilities of the individual you're helping and recognizing that what they really want to know are the key decisions that help them make a progress in the way that they feel. And I'll cover off some examples of this, or an example of this with a high level of a case that I'm managing at the moment in a short while. Now, the challenge that you probably have in your own life without the additions of doing all this extra training is that there's a balance that we try to hit. One is that we wish to be successful, which means maintaining a financially viable practice that provides outcomes, that generates reward for the people that come to see you, i.e. they feel better, but they also satisfy that inner desire why we all get into the care profession in the first place, which is to help and see somebody change from being an unhealthy or unhappy or ill person to someone that becomes much more capable of living their life unburdened with some of the challenges that they perhaps presented you with. And so managing that increased opportunity, I've seen this happen many times where the enthusiasm to deliver the information, of which I've been guilty of myself in the past, can be at a level that exceeds the capacity of the individual to take the information away and apply it. And that just comes from the heart because we're full of excitement and enthusiasm about the new tools that we have. So in addition to the educational programs that we do with IFM and prescribing lifestyle medicine, we also provide business training programs, case management programs, and after the AFNCP event that we're running in the UK this year, we're doing a masterclass in the day following the completion of that course, where we're addressing some of the very common questions that appear, not just in the UK, but internationally. So for physicians, it's always a case of how do I manage a transition from either a state-sourced type of healthcare to where I'm delivering a mixture of medical and lifestyle changes. For the non-medical professionals, osteopaths, nutritionists, naturopaths, etc., it's often how do I ensure protection against any claims that are made me? Does my current insurance policy work? Is the business model that I'm using working? Should I remain a single practitioner? Should I work in a practice? How do I ensure that my fees reflect the time that I spend on it? I think these are all questions that if we're not familiar with now, we are at different stages of our professional life. And so with the masterclass, what we do is break that down to some presentations from colleagues that have been through this process or professional people who are also clinicians or specialists in that area to explain different strategies that they've applied which have worked. And I know when I was in practice full time, I was always looking to try and understand how to improve throughput, how to improve the number of people I saw. I used to see 100 people a week for many years. And so trying to work out how to manage that patient list efficiently and effectively for them, I was always looking to try and find solutions. And so over the years, we've always looked to add solutions to the presentations that we offer. Now, what sort of clients or patients tend to seek out functional medicine practitioners? Well, the Institute of Functional Medicine holds a database where patients can go on their website and look for practitioners who've undertaken their training at different levels around the world. So there are some people that have already identified that the perception that people who've trained in functional medicine will be able to untangle their health concerns can go there and find somebody that's geographically local to them. But many practitioners, of course, offer telemedicine. So if they don't require a physical examination, or at least not too much of a physical examination, they can sometimes choose people by telemedicine requirements these days. But I'll tell you that the majority of people that seek out individuals that have undertaken this training are complex, long-term, challenging cases. Some of the most rewarding to untangle, but also some of the most challenging to manage. And if you enjoy that sort of patient process, then if you undertake functional medicine training, you'll be more adept, I should say, at helping them to recover. But you'll also find by circumstance, if you're not already attracting that type of patient to you, then you'll find that you are, once you become embroiled in the functional medicine educational programs. So I've thought that what we might do at this point, I can see we've got some chats coming in. Let me just check there's nothing there that I need to answer for you. Okay, so the question that I want to be clear is that the educational programs that we run for the Institute for Functional Medicine are aligned with UK timings, not US timings. So, for example, we'd be 1 hour apart if you were in Denmark or most of Europe, as opposed to 8 hours or 9 hours is sometimes the difference with the US. We regionalize the slides that come to you so that measurements that would perhaps be unfamiliar in US measurements because they're non-metric are all converted into measurements that relate to either UK or EU blood tests or lab work. We also try to make sure that we include data sets that are reflective of our European population rather than just for North American population. So the educational program originates in the US. We are authorized educational partners with clinical education and have been for 12 years. We use the information that the US presentations do because you see them as a recorded presentation, but the slide decks that you receive are slightly different in that they include measurements that make sense for European and UK practitioners, and they also include a few extra slides that include additional data. However, it is also possible for you to undertake the training by flying to the States, where they have in-person training, or you can join an online US training program, but you'll pay just under $800 more if you join the US program than if you join the UK EU originating program. So we provide a regional discount and regional timings, which makes it much more bearable. You're not sitting up till 2 o'clock in the morning listening to presentations. You do this during a normal working day. And then it's online and in person this year. And then for the advanced practice modules, which are the 2.5-day ones, they're all online for the time being. So I'm hoping that clarified a couple of the questions that came up earlier on. Now, I showed you this very colorful picture of a tree, which is effectively, I mentioned to you about looking for the root cause, and you can see at the bottom it says personalizing lifestyle and environmental factors, taking into account people's psychological history and well-being, what genetic predispositions they may possess, their own experiences, attitudes and beliefs, trying to identify what the antecedents, triggers and mediators are that may be leading to this person having dysfunction within the systems that IFM split out, at the end of which they tend to present with the symptoms that sit at the top of the tree. Our job is to work our way back down to the roots to identify where we would intervene and how we might do that. So I said to Anne-Catherine that I just give you a high-level example of a case and try to see how you would feel, where you might start, whilst you listen to me just give you this presentation. So I saw a adult male. He's 39. He's married with 3 children and runs his and his father run a construction business, which is fairly stressful. He's a type 2 diabetic. He has a very persistent reflux problem. He's also a celiac. He's reacted to multiple foods outside of those which contain gluten. He has been involved in various motorcycle accidents which has included a rebuild of his left tibia. He has a fracture of his left femur, which has been set badly, and this has led to a discomfort in his left knee, which will require replacement, but currently is reliant on painkillers and injections into the joint. He has a damaged neck vertebrae, which leads to bilateral paresthesia in both hands, and he's had a fracture of T7 and T8, which have been stabilized with screws and pins. So he has a number of bits of metal in him. He has a metabolic disorder with diabetes, which he struggles to control. He's celiac, but works in an environment where access to easy collection of food, he's often on farms, a long way from anywhere to get shopped, which inevitably leads to poor decision making. He's hypertensive. He's on antihypertensive medication. He's on omeprazole on 40 milligrams a day in order that he can sleep at night. He's on an insulin pump, which he manages through a combination of two different measuring tools. And he's probably 3 to 4, well, in kilos, he's 12 to 14 kilos overweight. And that weight will fluctuate by as much as 3 kilos within an hour after eating a food that is provocative to him. So I want you to think, just for a moment or two, that this person has turned up at your practice. He's filled in some questionnaires, so you haven't had this as I've given it to you now, it just dropped on you. But it's come in, and his questions are as follows. I'm worried I'm not going to live long enough to see my children grow. I'm in pain all the time. I really struggle with my weight. My concentration is struggling. I'm fearful that I'm not going to wake up in the morning because I'm worried I'm going to have a hypo overnight. And I don't know what to eat anymore. I've been diagnosed celiac. I don't eat gluten, but sometimes foods I ate yesterday were fine. I eat 2 days later, and then I react to it. Now, each of you at this point will probably be thinking this is a perfect person to refer to a colleague, and you'd probably be right. But realistically, we're faced with this challenge. So he has a number of wishes, which is that he wishes to reduce the level of anxiety by feeling more in control of his health. And he's come to you to ask, where shall I start? He's under primary healthcare and secondary healthcare management. And so we sit down and we try to infiltrate the process. Let me just quickly check those chats. Is he eating gluten-free oats? All oats without exception called gluten, and most celiacs are not given this info. Afifa, I did not ask that question. And obviously you're right in that most oats can get cross-contaminated, but his breakfast, when I asked him what he was eating, did not include porridge or oats. So I didn't pursue that, but it's a perfectly reasonable question to think about asking. But let's have a look at this chart here. So antecedents. So there's some problems with his genetics. His father is also a celiac. I've known the family on and off for some years. Father is celiac. Triggering events, we know that this is a mixture of environmental triggers and work-based triggers amplify many of his symptomologies. And his mediators and perpetuators are that if he is really, really strict and tries to avoid any form of triggering event, then he can function, but only on the basis he's taking antihypertensive medication and 40 milligrams of omeprazole per day, plus his insulin per day, and his life feels very compressed. By looking at the chart, and I think you can see this when I show you this area up here. By looking at the area up here, do any of you have a feeling? If you want to drop on with a microphone at this point, just identify yourself, it's absolutely fine. You can ask me a question, or you can say, well, on that very brief introductory history, and no one's asking you to commit to making a decision on this individual. Don't worry. Is there something? Is there anything in this area here that you might think you would focus on? And if so, do you have a rationale for doing it? Is there something that steps into okay, so Delia's come up with a suggestion. Thank you, Delia. Okay, so Afifa, you're keen that he gets moved straight onto a ketogenic diet. Anybody else have any other ideas? Okay, well, let's say that there's a fundamental underlying inflammation problem running with this person. He's got multiple levels of dysfunction, both endocrine, metabolic, physical, psychological. Anywhere on this chart, you could realistically put a pin and could probably form a strategy based around that process. So for me, what I began to think as I was listening to his story is that how can I reduce the overall environmental pressure on his body? What barrier might not be working as efficient as it should do, based on the fact that he experiences varying responses to non-antigenic foods at different times? So I see we've got some chats coming through, 3 or 4. Okay, so there's a metal allergy test. Yeah, we could certainly consider doing that. Sympathetic overactivity, yes. Poor microbiome and leaky gut. Okay, so Nesta. All right, so I hear from Anne-Catherine that you're going to be having a conversation with the next speaker, looking at the relationship between the microbiota of the gastrointestinal tract, the enteric immune system, and subsequent range of different types of potential problems that originate from that. So what Anne-Catherine indicated at the beginning was, I've been involved in research into the mucosal immune system and its relationship with the bacteria inside the gastrointestinal tract for over 20 years. I've published numerous papers on this, and I've also presented on it for many, many years. So my natural instinct is to think, I wonder if the thing I know the most about might be a sensible place to start. And you can feel yourself getting pulled there. But at the same time, to me, this gentleman presented with a great deal of worry and anxiety. He has 3 young children, and he's looking at me and basically saying, will I be here in 10 years' time? I feel like I'm not going to be. Everything is running away from me. I really don't know what to do. So the mental, emotional, and spiritual component in the middle of this, he really wanted to be anchored. He really wanted to be given, I felt, some sense of control. So tempting though it was for me to target an area that's very familiar to me, the first thing I felt he wanted to hear was, I think there's something that we can do to address these problems that you're giving to me simultaneously. Now, stepping outside of the GI tract for just one moment, how many of you are familiar with the idea of microvascular occlusion or microvascular crystallization for vascular flow? I ask you this because what I didn't emphasize for you at this point, because it took a bit longer to come out in the presentation from him, was that 2 weeks ago he'd been at a rugby match to watch his young son playing rugby, and his feet and hands had swollen to such a degree that he could not walk off the pitch and had to be put into a wheelchair. And he had taken photographs of the limbs, which he then showed me on his phone, and he reported back to his GP, and who was asking him to come and see him, but it gave him no solution. So let's think back. He's diabetic, he's celiac, he's hypertensive, he has reflux, he's got multiple previous surgeries and fractures, for which he's recently undergone some interventions. He's overweight, he has a very stressful life, and environmentally he's becoming more and more intolerant. Those of you who've been following some of the discussions around infection, more recently with COVID, but with other viral infections, might be aware of the idea that some of the peripheral tissues suffer from occlusion because of small clots, microclotting, leading to this. And one of the characteristics of people with diabetes, of course, is they have poor sugar control, and we end up with peripheral vascular insufficiency. So we get retinal upset, feet upset, or hand upsets. So I asked him, what are your eyes like? So he's reporting loss of vision, difficulties in seeing at night, so changes to the quality of his visual acuity. So going back to this story, why does the functional medicine matrix? Because this becomes quite overwhelming. I think you're already beginning to think, gosh, you know, this poor chap is struggling at 39 years of age, and he really would like to make 60 or 70. He doesn't want to be disappearing in his 40s. There are multiple areas here, and we need to be thoughtful, recognize the practicalities of what he might be able to do, and at the same time tease through, is this a defense and repair? Is it energy, because he's also describing that he's tired? Is it biotransformation and elimination? Is he able to break down some of the chemicals from the pins that he has in his body? Could those be contributing to it? Is it a transport issue? Why did his feet swell? Why did his hands swell when he was standing still for a while? What does that suggest to us? Is it a communication issue? Is there something here in which the immune system, the hormonal system, the vascular system are no longer able to communicate with each other without creating some form of cascade of defense response or inflammation response? Is it the structural damage to his body? He's got fractured vertebrae in his back, he's got fractured tibia, fractured femur, and fractured neck vertebrae. Is that a principal point? And then last of all, is it assimilation? Is he just not able to, is he over assimilating some foods? Are some foods crossing that gut barrier in too high a level, or is he not absorbing some foods? And when he does absorb some foods, why does his immune system trigger an antibody response when he swells? Now, I don't want you to think, because I haven't fixed this gentleman, I only saw him 2 days ago, but I'm just giving you an idea that functional medicine means that when you hear this sort of conversation coming, and you only have 45 minutes to come up with a communication to this individual that provides some form of strategy that he can go away and employ for 2 or 3 weeks before they come back. So I'll tell you what I did, and I'll tell you my rationale, and I'll tell you how I piece it together for him. Because if I just dump this on him, he's got to explain this to his wife. He's got to explain this to the office where he's working. He needs to be supported in this process. So I draw what's called a mind map, which is just a picture, which as I talk him through the story about how I think I can help him, I just draw a picture or pictures and link them together for him. So my view here is that I think he was experiencing, one, increased permeability of his gut. Now, let me just see how many of you said that. Did they check urine? Well, there's me, and the answer is no. It's all the areas you've mentioned. Yes, that's also a very good observation. Yes, I managed to cover all the areas. Big problem is overwhelmed, so you're right to go in by layers. Yes. Gut is obviously in the frame. Yes, Afifa, that's true. Grassroots, practical to move forwards. Liver, kidneys, adrenals. Yeah. Micro-occlusions peripherally can become a centralized issue. Yes. And one of his great concerns, of course, is not waking up because he suffered a vascular incident. Hand him on to me. Yes. Well, I'm not sure who said that, but Afifa, yes, she's very keen to get them. Yes. And yes, did you investigate his B12? Well, yes, Afifa, I did. So one of the questions I asked is, are you receiving B12 injections? For obvious reasons, we have a long history of omeprazole. That leads to B12 insufficiency and, of course, contributes towards fatigue. But his B12 only has a transitory benefit for him, which we'll move on to in a minute. Definitely give him confidence, steer on practical. Okay, food, approach, lifestyle. Yeah, I have a patient like this. Afifa, you're just a star. You know all the answers. Well done. So, low stomach acid, remove extra intolerance. I think that those of you who've worked with patients that are on high dose of omeprazole will be familiar with a rebound response. He has tried to self-wean off omeprazole in the past, but he gets terrible rebound reflux, and that's not where we would start today. That's certainly a prospect, but not for today. So the model of functional medicine familiarized me with a series of explanations that I felt could make sense. One is I explained to him that I felt that it was quite likely that a number of the foods that he was consuming might well be benign, but because the ability to translate the conversion of that food into energy and into our cells relies on a mucosal barrier that's highly permeable in the face of different types of challenges, particularly where you're taking large doses of painkillers, that would contribute at least in part to why some foods some days are more problematic than others. You may or may not be familiar with the fact that the lining of the gastrointestinal tract consumes 40% of our total metabolic energy per day, roughly, give or take 5% each way. If that barrier becomes compromised or has to be replaced more rapidly because of damage to the villi, then that naturally consumes energy. And whilst looking for the sympathetic system and the adrenal system will inevitably fall into some sort of work, I didn't think that was my primary point. I was concerned with the microvascular recent episodes of him getting swelling fingers and hands. And so one of the things I wanted to do was to think, how could I reduce his blood pressure and how could I improve the microvascular circulation? Because he couldn't sit in his vehicle, he couldn't ride his motorbike without suffering from some swelling, and that was denuding him from some level of enjoyment, but also some capability of work. And then the B vitamins that we touched upon, B12, typical significant deficiency. I did not test him for B12, but his GP was due to do another blood test on him next week. So I asked if I could have a copy of those results, and I've given him some B vitamins in the meantime to start. So to try and make this as simple as possible for him, I drew a picture of the gut, very simple one from mouth to anus. I showed him the stomach, the small intestine, and the large intestine. I showed him what little villi look like when they're healthy and next to each other and making a tight junction. I showed them what it's like when they're taken apart. I explained to him I was going to use a product which I believe Anne-Catherine might well have on her site called Permavite, which is developed by a gastroenterologist called Leo Galland many years ago, which we utilize for restoring epithelial integrity in the gastrointestinal tract. I explained that if you have a leaky or a change in the quality of the permeability of the gastrointestinal tract, it's highly likely that it'll have a blood-brain barrier that's no longer as efficient as it was before. And that will also contribute to a transfer of cytokines or chemicals that get released in the immune response in the gut to irritate focus and concentration. I said I'd like him to continue working very hard on his gluten avoiding program because he's been doing that for quite some time. I wanted him to take some stewed apples. Now, this is a very simple technique which I've utilized for many years, but stewed apples cooked with some cinnamon and a few raisins provides a food that most men are happy to eat. And not all men are great patients, as every person who's ever treated men will know. So I try to find a food that the wife can prepare quite easily, and they use that because pectin, which is released when you cook apples, modifies some key toll-like receptors in the gastrointestinal tract and reduces overall inflammation. And then I gave him something called nattokinase. Some of you may be familiar with nattokinase, but nattokinase is an enzyme derived from fermented soy. There are over 500 papers published on nattokinase in PubMed. If it's not an area you've ever explored, it's very safe. There are no contraindications. It doesn't conflict with any of his insulin or his medication for diabetes, which is a consideration we have to keep in mind here. But I've used it multiple times on people who are hypertensive. And even in older patients, I've seen reductions in blood pressure by 25 to 30% over a period of 6 months. We've also used this for vascular insufficiency in diabetics, where they're getting peripheral neuropathy and starting to demonstrate necrotic tissue changes. You can improve the flow of blood to those tissues, which I wanted to do to try and reduce the amount of swelling in his limbs. So I left him with 3 things. from me. One was a program to help repair the gastrointestinal tract. One was to improve peripheral vascular flow. And the other one was to repair membranes, i.e. the permeability of membranes, together with some strong supportive advice that he has the vitality in his age to repair. If he's given the right raw materials, he understands how they will interact together during the use of this program, that we'll have a look in 3 weeks' time and see how he's got on. He's going to record his resting pulse for me, and he's going to record his blood pressure for me on a daily basis. He'll chart that. I know that it'll be done by pencil on a piece of scrappy paper, and I'll have to convert it to an Excel file. But essentially, I'm going to convert those readings and begin to build a graph so that I can track what changes occur in his blood pressure. He's going back to see his primary care physician to advise him of the interventions that I provided. I know his GP from having worked in the area I live now for, as I say, for 30, nearly 40 years. So the GP knows I'm not going to be giving him something that will create some problems, but I'll probably get a phone call just to go through in a little bit more detail about why I've done what I've done. So I've given you that idea. One, to just get your brains thinking. Obviously, Afifa would like him, so I'll keep that in mind, Afifa, if you're not too far away. The others of you, I think, yep, you've all got eggs and bacon. Yes. Nattokinase, good. Someone's already using that. You're using it for sclerodema. Well, good luck with that. I hope that works well. Yeah, raising and lowering legs. Yeah, you're absolutely right. He already does that. So he does sit at the end of the day with his feet up to take down some of the swelling in his limbs. So obviously I can't cover absolutely everything. We've only got a short period of time, but well done, everybody. All your suggestions touch on these points. But I'm hoping what we come away from here is not that I was able to think of some solutions for him, but more that by understanding how to integrate lots of different systems simultaneously, it was possible to pick a way. And you may have come up with a very different way. It's not to say it wouldn't have had a successful outcome. I don't want to imply this is the only way. The great benefit of functional medicine training is that you could perhaps come in from a slightly different position and still end up with a very good outcome, because you can understand how the systems work together and plot accordingly. Right, well, look, let me know how it goes. We'll perhaps do it. Anne-Catherine can do an email in a few months' time and make sure the poor chap's still alive and doing okay. So what I want to show you here is, just before we go to finish off with Anne-Catherine coming back on, is that clinicaleducation.org, if you feel like you'd like to learn a bit more about this training program, if you go onto that website and look for Applying Functional Medicine in Clinical Practice, you can see that we are doing from the 20th of June to the 20th of September, the training programs are online, so you can do these from home. And from the 22nd to the 23rd of September, we're in person in London. We're hoping to have a couple of hundred people together with the various people that support us, like Nordic Laboratories, where everyone have a chance to meet and talk and chat to each other. Right, Anne-Catherine, I hope that I didn't babble on for too long, and it was at least interesting at one level.
It was just how I had hoped it would be, Mike, when we invited you. So thank you very much. And it was amazing how you included all the audience in your presentation. And I think everyone stayed. We are still the same amount of people who joined. So that's always a success when it's the same people who stays all the way through. So, and of course, we will send out the invitation or the links to where you can sign up if any of you have gotten hungry for wanting to join the IFM AFMCP course. So thank you everyone for listening. Mike, thank you for your presentation. Reach out if you have any questions, either to Nordic and DNA Life, or even to Clinical Education. You have the website and the whole presentation, and we did record it, and we will share the recording. And it might be nice to just go through this case presentation just one more time to have some extra notes for your job and clinic tomorrow. But it's interesting how I just want to touch this point. So actually last week I had a patient who is well, it's taking about a year to get close to a diagnosis with scleroderma. And now Afifa mentioned that, and you mentioned Nattokinase. And I was looking into this high dose vitamin D protocol for autoimmune conditions and looking into scleroderma. And you've probably experienced this, how things just, it's like the pieces in the puzzle just comes together within like a week, when something is just like, you need to investigate something. And sometimes it's for maybe for 1 year, you get a lot of patients with ADHD, and then the next year it's something else. So the patients kind of choose you. There's an energy around a topic sometimes. So this continual education, I just love it. And I just thought it was a fun experience now, this being mentioned whilst I'm in my continual search in order to support this patient of mine. So thank you all for joining in with that. I wish you all a great evening, and especially you, Mike. Take care, everyone, and hopefully see you soon. Maybe at the next webinar we have. Bye.
Thank you, everybody. Bye-bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.